Hey everyone, welcome back. We are jumping right into part 2 of our explainer series on ICD-10-CM Chapter 15. If you hung out with us for part 1, you know we're all about precision in practice, setting a really high compliance-focused standard for every single chart that crosses your desk. Today, we're taking a deep dive into 2 incredibly specific, and honestly, heavily scrutinized areas of maternal care coding.
Okay, let's dive into this. Here's our roadmap for today's explainer. We'll start with O09 for high-risk pregnancies, tackle a quick case study, then move into O10 through O16 for hypertensive disorders, do another case study on postpartum hypertension, and wrap up with our key takeaways.
All right, Section 1, welcome to Part 2. We're moving past the introductory concepts today and stepping straight into the strict guidelines around high-risk pregnancies and hypertensive conditions. Our focus is absolutely crucial, and I want to remind everyone exactly why we're doing this. The goal is flawless OB/GYN compliance. We want to literally eliminate those claim denials that happen just because of a sequencing error or some missing documentation. Mastering these specific code blocks is exactly how you protect your organization's revenue cycle.
Moving on to Section 2, O09, high-risk pregnancy.
So what's the deal with the O09 block? These codes are strictly for capturing routine, ongoing monitoring of pregnancies that have been flagged as high risk. We're talking about things like advanced maternal age, your elderly prima gravida or multi-gravida charts. It also covers complex obstetric histories, like a previous ectopic pregnancy, infertility, or pre-existing underlying medical conditions. Basically, if your provider is monitoring these known risks during a standard, routine visit, O09 is your go-to category.
But, and this is a massive but, you've got to burn this rule into your memory. O09 codes are for routine antenatal visits only. Never, ever use them for acute complications. Honestly, this is a super common pitfall we see all the time. If your patient comes in for an active delivery encounter or has an acute issue like a hemorrhage or active preeclampsia, O09 is completely off the table. It is for routine supervision only, guys.
What's really interesting about this workflow is how it clearly maps out the absolute requirement for mandatory pairing. You can't just toss an O09 code on a claim and call it a day. That's a coder's worst nightmare for a denial. Step 1. Lock in your primary O09 code based on the specific risk factor. Step 2. Validate the exact trimester. And Step 3, which is totally non-negotiable, always append the right Z3A code for gestational age. Remember, gestational age is never optional here.
All right, Section 3. Let's do a case study on high-risk supervision to put this into practice.
Imagine this chart just hit your desk. A 32-year-old patient comes in at 14 weeks gestation for routine care. Her history shows a right tubal ectopic pregnancy from 2 years ago. The provider documents supervision of high-risk pregnancy due to history of ectopic pregnancy. So, how are we coding this? I'll give you just a second to lock in your answer.
Did you guess O9.12? If so, you hit the nail on the head. Let's break down the logic. The documentation clearly states it's a routine visit, making O9 perfectly appropriate. The risk factor is the history of ectopic pregnancy, pointing us straight to the O9.1 subcategory. And since she's at 14 weeks, she's officially in the second trimester, giving us that final character of 2. And of course, in the real world, you'd absolutely pair this with Z3A.14 for the weeks of gestation. Beautifully done.
Let's keep rolling. Section 4. O10 through O16. Hypertensive disorders.
Okay, hypertensive disorders during pregnancy can be incredibly complex to code because the clinical picture just changes so fast. But this breakdown brilliantly illustrates the fundamental split you just have to memorize. On the left, we've got pre-existing hypertension under category O10. The magic rule here is timing. It was diagnosed before the pregnancy or before 20 weeks gestation. On the right side, you've got gestational hypertension mapped to O13 through O15. This is pregnancy-induced, meaning it pops up after that 20-week mark, and includes conditions like preeclampsia and eclampsia. That 20-week mark, that is your absolute dividing line.
So, the crucial point here is that without extracting these 4 exact pieces of information from the provider's documentation, you literally cannot assign an accurate code. You need the trimester, first, second, third, or postpartum. You need the severity, is it mild or severe? You've got to catch any complications like proteinuria or seizures. And, like we talked about earlier, gestational age. Always pair with those Z3A codes. If you're missing any of this, you know what to do. It's time to query your provider.
Let's look at a few examples to see how these elements dictate your final code. Take O10.013. That tells a complete story. pre-existing hypertension complicating a third trimester pregnancy. Or look at O14.03, which captures pregnancy-induced mild preeclampsia specifically in the third trimester. Then we have O15.2, eclampsia postpartum. Notice how just changing the timing to the postpartum period completely shifts the code you're using. Precision is everything here.
Section 5, Case Study, Postpartum Hypertension. Let's see how you handle this one. All right, here's a slightly trickier scenario for our second verification check. A 28-year-old patient is in for her 2-week postpartum follow-up. The chart notes say she had gestational hypertension during her pregnancy. Today, her blood pressure is still high at 150/95, but there are absolutely zero signs of preeclampsia or eclampsia. Think critically about the timing here and the lack of systemic complications. What do you think is the most compliant choice?
The correct code is O116.5, unspecified maternal hypertension postpartum. Now, why not use a pre-existing code? Well, because our history explicitly says it was gestational. And why not preeclampsia? Because the provider noted there weren't any signs of it. Since the elevated blood pressure is isolated in the postpartum period without any preeclampsia symptoms, O16.5 is for sure your most accurate bet. Which brings us to Section 6. Let's wrap up with our summary and key takeaways.
Here are the core rules you'll want to keep printed next to your monitor. Number 1. O09 codes have a very strict limitation. They have for routine prenatal visits only, no acute stuff. Number 2. Always distinguish O10 from the O13 through O15 block by strictly looking for that 20-week onset mark. Number 3, mandatory Z3A pairing. Gestational age is never, ever optional. And finally, always validate the trimester, severity, and complications. Getting these exact details right is exactly what stops those annoying downstream billing failures in their tracks.
You've now got a solid, structured framework to handle these complex, high-risk, and hypertensive charts with total confidence. But here's a thought to leave you with. If your providers are consistently missing that 20-week documentation mark, how much revenue is your facility quietly leaking every single month? Challenge yourself to audit just one of your recent hypertension claims today and see what you find. Thank you for watching and stay tuned for Part 3. This is Decode Healthcare with Harshal.